Very good morning. Now, see, this is today's topic, congenital heart disease. But yes, I divided it into two parts, part one and part two. Because again, the topic is so interesting, so many things to know. So it's like it would be an absolute injustice to the topic if we try to finish it fast, right? So that's the reason I've divided into two parts, and and the division is as per the classification, right? We'll see it in detail, but like acyanotic and cyanotic, these are the types of classification. So we'll take one today and the second one tomorrow, plus the AV malformation. So that's how we shall proceed. But today's session, that would be full of 2D echo, 3D echo, angiographies, chest x-rays, CT scan, right? So that you get a very proper concept about each and every condition. Very important even in your, say, entire medical life. So here it is, the congenital heart disease, part 1. When we say congenital heart disease, the easiest explanation to it is that whenever there is any deviation from normal embryology, because that is what is congenital heart disease. So what can go wrong? Some defect in the structure, right? Or some function is affected, or some vessels are involved. Those vessels which should remain open, they are obstructed, or those should be obstructed, they remain open, forming the abnormal path. So that's it. Everything would revolve around these concepts. So our action plan would be that whenever we'll be talking about any of the specific this congenital heart disease, first we'll talk about very briefly about its embryology, and then we'll dive into that particular disease. Idea is that you should be crystal clear about what we are talking about. So here is the classification. Acyanotic. So your patient, that baby, will remain pink. He will not turn blue, as in case of cyanotic. So over here, what can go wrong? Well, there would be volume and pressure overloads. How come? The volume and pressure overloads. All we need to understand is these are the four chambers which are separate. Right atrium, right ventricle, left atrium, left ventricle, and then there are specific blood vessels, correct, which are going in or out. Everything is separate. There would be valves, so even valves, they are separating them from pulmonary trunk and the aorta. If anything goes wrong in the form of, if any of the two chambers they are communicating, so it means blood would start mixing, and there is definitely a difference in the pressure on the right side and the left side. So entire game would be one, what would happen to this pressure? And second, what would be the direction of blood flow? Rest of the things, they are self-explainable. You'll understand them without any effort by yourself. In fact, 2D echo, 3D echo, when you'll see just by looks at it, you'll be able to say, okay, it is this. Right? So here it is. For acyanotic, this would be our topic for today. But that much only. So ASD ASD is atrial septal defect, right? So it is atrial septal defect here. The second is ventricular septal defect. So that is over here. Then this is PDA. So that is VSD is ventricular, right? Ventricular septal defect. PDA is patent ductus arteriosus, right? It is patent ductus arteriosus. Now, what was this ductus arteriosus? Well, ductus arteriosus is like, if you go back and you remember that in fetal circulation, right? In fetal circulation, lungs, they are of, that is the fetal lungs, they are of no use. So that's why the entire blood with the oxygen is coming via placenta. So it means from right ventricle, it is sending this blood to the lungs. Okay. So what we do? Pulmonary trunk, right? As it emerges, as it is going into both the sides, it creates a channel. So a channel is created between pulmonary trunk and the aorta. So that blood is shunted into the aorta. When this blood is shunted, it means that it will not be going to lungs, and this path is called as the ductus arteriosus, right? Ductus arteriosus. Later, as the baby is born, when the pressure gradients change, right? Lungs, they open, resistance fall, prostaglandin stop. So this ductus arteriosus would be converted into, say, ligamentum arteriosum. So this is normal. But in case if it is not happening, this remains open, then there will be so many new things developing, right? So that is PDA in nutshell, ASD, VSD and PDA. And the last one which we'll be discussing, that is coarctation of aorta. Coarctation means narrowing. We'll say it like coarctation, ARCTATION, coarctation of aorta, right? We'll watch all these conditions in depth. Rest of the topics, that is in cyanotic, blue baby, regarding this pulmonary blood flow, increase, decrease, tetralogy of Fallot, or transposition of great vessels, etc. All these things, right, they are for tomorrow. So that will take tomorrow. Right? So right now we need not worry about it. So let's focus on our today's topic. Coming up, the first one, ASD, atrial septal defect. Now, as we said, that we'll talk very briefly about its embryology. And as you must have guessed, if you have studied embryology properly, immediately you will say that yes, what we are talking about. What we are talking about is this, that say that's our right atrium and this is our left atrium. What we are interested in, how the atrial septum is formed. Well, atrial septum, it starts from the top, right? And it starts developing. This is what is called as the septum primum, right? That is called as the septum primum. And this septum primum, it all the way it grows, right? It reaches to that endocardial cushion. So it reaches to this point. But when it reaches over here, right, then a small portion, it disappears. So that's what is called as, this is the septum primum, and in order to fill it, there is another septum which is developed. Right? So this is what is called as the septum secundum. When there was a gap over here, so we called it ostium primum, and this particular gap on that side is called as the ostium secundum. And then because this thing is acting as a valve, so this is what is called as the foramen ovale, right? Foramen ovale, which is acting like a valve. It allows the blood to go from right side to left side, right atrium to left atrium, because it is necessary that this entire blood should go into the circulation and not into the lungs. Fine. Once the baby cries, the pressure rises over here, right? It falls over here. So relative rise on the left side. So this septum closes, and that's the reason that in anatomy, when we open the right atrium, what we really see in it is fossa ovalis, right? Fossa ovalis, which is the monument telling that once upon a time there was a foramen ovale and the blood was passing from right side to left side. Okay, so here it is ASD, where we call it left to right shunt, right? This is left to right shunt because left side is with high pressure. Right side, which is handling the blood which is received from the body and it is sending to lungs, it is relatively at a low pressure. So this is the septum. When there is something wrong in this septum, whenever this septum is defective, so obviously the blood would start shifting from left side to right side. So see what happens. Everything is related to this. The first thing which happens is pulmonary congestion. Why? Such high pressure blood which is coming into the right side would say that I can't handle this much, so it will send this right atrium, it will send this blood to right ventricle would say that how can I store it, send it to lungs, and it would be sent to lungs via pulmonary trunk. Now in lungs there is more blood as compared to what it has to be, right? This is what would lead to pulmonary congestion. Now, how many types of these ASDs they can be? See, the commonest is secondum ASD, right? Secondum ASD. So, in which case this primum secondum, right, it fails to develop, or there are some holes in it, and somehow that ostium secondum remains open. So this is the path which is patent. Then say primum ASD, so in which this septum primum was having problem. Then if you remember in right atrium, right, superior vena cava opens, inferior vena cava opens, and then the sinus venosus that also opens. So over there it can be on sinus venosus ASD, but this is just 10%, right? It is near SVC or IVC. And in very rare cases, there are no septum. So this entire chamber is acting as one only, right? No septum. So this is what is called as common atrium. This entire thing is like common atrium. Very rare. The commonest is what you see is the secondum ASD, right? More in females as compared to males. So ASD would look something like this. That is what would really happen, right? So here is our right atrium and we are getting the oxygenated blood from left side and it is coming towards the right side. Let's see the hemodynamics, what really happens. So as we saw that initially ASD allows an left to right shunt, left to right shunt. Why we are telling initially, right? What is like this initially? Because when we say that left atrium, right atrium, so this is left to right shunt. Well, this is okay, but actually it is initially because the body, it keeps on adjusting the things, right? How it adjusts? Say oxygenated blood from pulmonary veins and left atria, they enter right atrium, right? So over here, this is having that oxygenated blood which is coming from those pulmonary veins, and then that blood is getting pushed. And it is this oxygenated blood, it is now recirculated into the lungs. Once again, it is going into the lungs. So already from lungs, the blood is coming over, is sent, and from left atria, once again, it is rerouted and it is once again coming to lungs. So the entire load is now on lungs. That's where the congestion would occur, and because it is in lungs, it is pulmonary congestion. Now see, pulmonary congestion, right? That's okay. It will start rising. At one point, it would happen that the pressure in the right side is equal to pressure on the left side. Because there is so much of congestion, because this is a non-stop process. It keeps on happening on and on and on. So at one point, say their pressures are equal. And the worst thing starts now. When the pressure over here rises above the left side. So in that case, the shunt is reversed. There is a reversal of shunt. And now the blood from right side, it starts going into the left side, and there starts the all trouble. This is what is called as the Eisenmenger complex. So we'll see this thing in detail, so much so that how to diagnose it from the x-rays. So we'll be watching all those x-rays, CT and everything, right? So basically it happens that it causes right atrium, right ventricle and pulmonary artery dilatation, right? Right atrium and pulmonary artery. Yes, because they are now getting overloaded. So this is like right overload, right side overload, right? Quite logical. Okay. All right. So let's see further. This is what we were talking about, Eisenmenger complex. So eventually there would be pulmonary hypertension. That's what we said, that there would be rise in the pressure on the right side, right? And this pulmonary hypertension and pulmonary vascular obstruction, because there is so much of blood now getting deposited over there, right? It is moving slowly, but it is rising in its pressure. Right to left shunt starts, and this leads to systemic desaturation and cyanosis. Why? Because now on left side, instead of pure oxygen, what is getting dumped is the blood with the carbon dioxide, right? So here now it is the mixed blood which is circulating, and this mixed blood will lead to cyanosis, right? The bluish discoloration. This is what will start happening, and then there would be complications of this Eisenmenger reaction. This system, that is reversal of shunt, right? So I'll just write reversal of shunt. That is what is called as the Eisenmenger reaction. What can really go wrong in this? So many things, right? So many things. So let's start with ASD first, and then we see what will happen in Eisenmenger. Now symptoms are like, sometimes they are not be seen if it is very small. So in childhood, no one might even know about it. But slowly and gradually pressure is rising, right? Because it takes quite time and depends upon the size of the ASD. So frequent symptoms in patient with a large ASD. First, fatigue, right? Everything is normal, but because your patient is losing oxygenated blood because of left to right shunt, so actually the blood which should be reaching to all the tissues, that is not available, right? This is decreased. So obviously it is like fatigue. Frequent upper respiratory tract infection because of that congestion. Failure to thrive. Thrive means it is like that expected growth and the development, right? That is stunted, that is decreased. Stunted growth. Dyspnea on exertion, breathless. Your patient is breathless on exertion, because normally though it's okay, but when because of congestion, right, it will lead to all that exertion. And second, the tissues, they are not getting sufficient oxygen. So these are the symptoms, but still that baby is not turning blue, right? He is not turning blue. He is pink only, normal. So it means there is no cyanosis. Now when Eisenmenger occurs, obviously there would be cyanosis, because now that carbon dioxide blood has entered into the left side. It has entered into left side. Now when it has entered into the left side, it leads to cyanosis. Fatigue, no doubt about it, and the exercise intolerance. Because whenever you do exercise, you require large amount of oxygen, and now you are getting, say, mixed one. So obviously your patient will complain that exercise is intolerable. And the complications of Eisenmenger reaction, in fact, there are many, but these are like cyanosis, commonest, stroke, right? Right-sided heart failure, because now Eisenmenger reaction, it can occur when there is so much rise in the pressure, there is so much of pulmonary hypertension, and it is this pulmonary hypertension which will lead to all these complications. So right heart failure, atrial fibrillation, so much so that mitral prolapse and tricuspid, that is mitral regurgitation and tricuspid regurgitation may cause death. This is one of the very bad complication of Eisenmenger reaction. It itself is a very bad condition. Now, how it looks like, now comes the interesting part. See, okay. The first thing which you will see is measure the distance from here to here, this distance. Let's say if it is A, and measure this distance. Let's say this is B. Immediately you will say that B is definitely more than half of A, correct? If we measure that entire A from this point to this point, and if we measure this B from here to here, right, we definitely know that this B is more. It means that width is more. This means that this is nothing but cardiomegaly. It is cardiomegaly, right? So heart is enlarged. Now when we say that heart is enlarged, when we say heart is enlarged, this is the right side of the border. You remember that part, right? When we said that you have to think it like this, that this is right atrium, right ventricle, left atrium, left ventricle. Heart rotates, right? Heart tilts and rotates. So it means on my right hand side, now on my right hand side, this is right atrium, right? In front is the right ventricle, and the left side is formed by, right? It is formed by that upper left atrium and the left ventricle. Left atrium would be going absolute posterior. So here it is the right atrium. So you can see the bulge. So that is right atrium which is enlarged. So first thing was cardiomegaly. Second thing, the right atrial enlargement. So far everything looks fine. But watch for this. These are what is called as the pulmonary markings. Pulmonary vascular markings. See, these are the markings, and if you very carefully see, this is going all the way to till the end, right? See these vessels, they are going all the way till the end, right? All the way, almost till the end. See over here. To appreciate it much better, I'm erasing it and I'll just zoom it so you can see it. See? Can you see? Right? Watch this area. Right? Watch this area. So that's the meaning that there are prominent, it is called as the prominent pulmonary vascular markings. Now this is for ASD minus Eisenmenger complex. That is, still Eisenmenger complex has not established. But these are the three important markings. And when you take the lateral X-ray, you'll find that even the right ventricle, that is also enlarged. So you have got these 1, 2, 3, and 4, and one more, and this is that there would be prominent main pulmonary artery. Main pulmonary artery. So see, these are the major findings of ASD. Right? That's what you get in ASD. Right atria is enlarged, yes, because more blood is coming. That more blood would be passed on to the right ventricle, so that is also enlarged. In between, that valve is there between right atrium and right ventricle, right? So due to that high back pressure, even that valve, this tricuspid valve, that may prolapse, right? It will be the prolapse. It will allow the blood to go back, right? Because the leaflets under strong pressure, they will give way. So there would be tricuspid regurgitation. And then due to this high pressure into the lungs, so all these vessels, they have become prominent and they are going up to the deep areas. That blood vessel, right, those pulmonary vessels, they are prominent, but it is getting taken by the pulmonary trunk and then into pulmonary veins, pulmonary arteries, right, those main pulmonary arteries. So that is what you see, that prominent conus main pulmonary artery. So that's the reason we are getting these findings, right? Let's see something more. Here it is. Now this is color Doppler. Now as we are discussing, because we'll be watching such images, several of such images today, tomorrow, the principle of Doppler is very interesting. When we see this image, it is not so that this red color is oxygenated and blue color. You can get blue color also. Blue color is deoxygenated. No. Doppler works on the principle of sound, right? So Doppler tells that there is change in the perceived frequency. There is change in the perceived frequency as the sound object is traveling. So here is a platform. Here is like all of us are sitting here, and the railway engine is over there, and it is that old Purana Jamana wala engine, right? And then it is giving a sharp whistle, right? How will you perceive it, right? As it is coming towards near you, right, it will start, right? That's how it will come. And if you are sitting inside the engine, so how will there be any change? No, it will be constantly same frequency. But when it is that sound, that source is moving towards you, right, you will feel that frequency is changing. That's why it is called as the change in the perceived frequency. And then when it is going, right, so then, right, and it will go. So it's the same sound, but because object is moving, that's why we found it different. Now over here also, what we are watching is, because we have connected a computer, so that's why we are converting these into the colors, these frequencies into colors. So practically, what we really see is that the direction of flow, it tells us direction of flow, right? Direction of flow. So think it this way, that if it is left atrium, right, that is left atrium, and that is right atrium, this is left to right shunt, How can I say that this is left to right shunt? Why can't I say that it could be right to left also? Right? Picture to would will look completely same. Not really. The probe is over here. So it's like we are watching from here, right? We are listening from here. And then if we close our eyes and when we see even on that platform, we close our eyes and then we try to listen to that sound of that railway engine and we feel that, right, it is increasing. So we say, yes, that engine is coming. It is not going. And then if it is going to, yes, we'll say, right, so it is means it's going. But the same thing over here. Over here, what you are doing is with this probe, you are listening the turbulence of that blood, that okay, it is increasing. So it is coming like this. And that's the reason it is left to right shunt, right? And as it is coming, so we represent it by red color. When it is going, we represent it by blue color. Let's say you put the probe over here and then you start measuring it. Yes, it will turn blue, right? Because it will be the other way around. Okay. This is another principle, right? That is echo. This is 2D echo. We'll see the 3D echo also. So this is 2D echo. Actually, this is showing us almost all the chambers. And it is very easy to figure out that what's the missing part. So that is right atrium, right ventricle, left ventricle, and we see that huge, big defect. There is a huge defect. So here in echo, what you are watching is actually the physical movements or the physical structure. Physical structure. See, in any of the investigations, always remember that what exactly it is trying to tell you. What's the purpose of that investigation? Sometimes we say that whether we should go for CT scan or USG ultrasonography, or should we go for MRI? Right? Everyone has got a different purpose. CT scan, yes, it is good. But what CT scan would show? CT scan would show the awesome anatomy. Right? It will show the awesome anatomy. So anatomy is seen. The structures, they can be seen very clearly. But in those structures, there is a problem. CT works on the principle of difference in the density, differential density. So if there is one structure over here, right, and there is another structure over here, and both these structures, they are almost of the same density, right? So in that case, we won't be able to differentiate between both. It would look like one complete structure, because CT scan, that would say that yes, I can differentiate between the densities. I'm not a camera so that I'll go inside the body, shoot everything, and then will come out and will show you on the screen. We'll say no. These are called as the sectional radiography, right? Sectional imaging. It is like a cross section. So in cross section, when the X-ray beam is actually passing through the body into that plane, and then it is perceived by those sensors which are on the opposite side, and with the Fourier analysis, they create a picture, right? That is what you get on the screen. So there has to be the difference in the density. But what if both these structures, they are as such different, their densities can be same? That is where MRI would step in, because MRI would work on the principle of that there is T1, T2. It works on the principle of magnetic resonance. So every structure, it is made up of different types and different energy levels of the electrons which are circulating and which are forming that particular substance, right? Once we'll be going into the depth, right, we'll be talking about only MRI, but this T1 weighted, T2 weighted, short, long T1s, right? When you give that pulse, you stop that pulse, then you are perceiving that energy and converting into image. So it is based on the principle of magnetism. That magnetism which is of very high intensity. And the third is ultrasonography. We can hear from 20 hertz to 20 kilohertz. Hertz means 1 cycle per second, right? So over here, if we are using ultrasound frequency is higher than our visual range. So we won't be able to listen. But over there, like a sonar system, like those bats, right? Those who are flying, when they will go, those waves will go, and when they will come back, you start creating the images. So all these images, they are created by computers, but with various different principles. This is where we see this atrial septal defect, right? Let's see more. Here it is. See, this is 3D echo. So once you have interpolated all values, it is the 3D reconstruction which is possible. So in this case, you can actually rotate this model, and this will give you a much better clue. That's what is called as the 3D echo. Right? In CT or MRI, there is something what is called as the 3D reconstruction. So you can actually reconstruct one particular section. So when you have taken all those sections, and then from every section, you pick up an axis, and from axis, you take all those points, you interpolate those points, and then you come up with a 3D structure, right? Okay, one more image of this 2D echo, and which is showing us good AST, atrial septal defect. Yeah, here it is. Now, in case of Eisenmenger reaction, what new things which we get? Well, first thing is Eisenmenger reaction occurs only when there is a reversal of shift. So it means from right to left it goes. So when the blood will start going from right to left, first thing, it won't happen that just in a single shot, right atrium will become smaller, right? It can't, right? That straight away, that pulmonary artery, that will become smaller. No, it took years. It took such a long time to develop this entire thing. So it cannot go as it is. But as the pressure is rising, the first thing is the moment there is reversal of shunts, those tiny vessels, tiny pulmonary vasculature, they will start showing you a difference. And that difference is, that's why that difference is this. Rest is all very, very logical. You already know it. But this is the clear, a very different thing. And what it is? It's a large right atrium. Yes, that's fine. Prominent main pulmonary artery. Sure. Enlarged heart. Yes, it would be. Right? Increased pulmonary vascular markings. Obviously, we don't expect everything to go away within a day. All right. But over there, because of increased pressure, these pulmonary vasculature, they were going distally, right? They were covering almost the entire area. Over here, you can see that distally, see, it is that entire thing is so clean, right? There are no blood vessels seen. Over here also, see the distally, distal portion, right? Distal portion. Over here, nothing, right? No blood vessels. So they are decreased distally, not means over here. Yes, you will say we can see it over here, or here it is seen, or here it is seen, right? Over here also it is seen. That's okay. Means it won't disappear from all the areas, but at least you will start watching it in some. Now, one question which was asked, right, as I was describing this in one of the other batch, they said that we are finding it difficult to appreciate that distally the vessels they have decreased. Well, it can happen, right? Because once you start watching more and more x-rays, you'll be more and more comfortable. So that's why I'm just removing this thing, right? I'm just removing it so that you get some idea, right? See, at least you can appreciate that this area is pretty clean, right? Pretty clean. Over here, though, it is quite a big area, right? Quite a big area which is pretty clean, right? They are devoid of those pulmonary vasculature. Right? This is because of that reversal of shunt. Okay, yeah, here is CT scan. Now in this, I would like to show you something extra, because in CT scan, as we said, that you see the anatomy very well, right? You see the anatomy very well. So over here, the moment it is shown to us, immediately we say that, okay, this is right ventricle. And over here, this one would be the right atrium. And then here is our ASD, right? And this is from right side to, say, this is our left side. So that's our defect, right? That's our defect. But when it occurs like from left to right shunt, when the blood was going like this, correct? When the blood was going like this from left side to right side, see the thing which I am trying to emphasize. This is what, these are the muscles of right ventricle, and these are the muscles of left ventricle. Since beginning we are talking about that always our left atrium is always stronger, bigger, powerful than, left ventricle. Just a minute. Our left ventricle is definitely more powerful, stronger than the counterpart, right ventricle. But here our left ventricle is this much, so even our right ventricle is also this much, right? Both are equally strong. Why so? Because it is right ventricular hypertrophy. Very nicely seen, very nicely. Now I'll erase all these markings, and then you see and try to appreciate these images, right? Try to memorize in your brain. As you will come across any of such structure, the moment you see that, yes, this is the musculature which I'm supposed to use. Now there are so many things, right? So for example, this is aorta, right? These are vertebra, there are some vessels. That's okay. That's okay. And again, there is a window, because some of the images, some of the structures, they have been diffused, right? Because of change in the contrast, so that you can see at least these vasculature properly. This musculature properly. So I'm just removing this. Just removing this. Now see. Correct? All right. So over here, think of this and this part. So that's where this is the right ventricular and the left ventricle musculature. That is the hypertrophy, right? It is enlarged. Let's watch this. Now how to say tackle such condition. Remember the name. It is called as Amplatzer occluder or Amplatzer septal occluder, right? You can say it like Amplatzer septal occluder. Now same device, right? Same thing I'll show you for AS. I'm showing it for ASD. Same thing is what I'll show you for VSD also. But there would be a subtle difference. What difference is? Say, in case of ASD, right? ASD is what? It is this. So actually, right atrium and left atrium, they both are weak chambers. They're small chambers, right? Their wall is thin. So it is this portion, it makes a complete sense, isn't it? That this in between portion, it should be thin, right? It should be thin, because it would be sitting, let's say here is the hole. Here is the hole. So this device, it has got two sides. I'll write it like 1 and 2. 1 is bigger, 2 is smaller. 1 has to be bigger on the side where there is more pressure, right? So we'll keep it like this. And the second part would be lying like this, right? So that's how the whole device would go. And this will occlude that opening. correct? But the two things we'll remember in this, that this is the, now I'll write it. Now this is the left side and this is the right side. So two things which we'll remember, no doubt once you'll go in cardiology, this one thing will come, but surely good to know. First thing, that its middle part is thinner. Middle portion is thin. So when you will be telling that let's get the amplitude for ventricular septal defect. Now your logic is so good, right? You will say that when the ventricles are there, so here there would be the ventricular septal defect. Okay, so here would be the VSD, ventricular septal defect. Ventricles, they themselves are so powerful chambers, so obviously their septum is also powerful. Septum is powerful, so septum is thicker. So in that case, we'll see that this middle portion would be obviously thicker. And both the chambers, they are super strong, right? It is not so any of them, none of them, they are that weak. So here we have to put it something like this. So there it would actually go like this, correct? That and this thing would become bigger. So that would be for ventricular septal defect. So right now, just we stick ourselves to this and we say left side is bigger than the right side, correct? Left side is bigger than the right side. Just these 2 points keep in mind, right? Will be very helpful. Okay. And how exactly the things look like when we really put it into the patient. When you put it into the patient, right, it immediately tells that what has been done. This is a fluoroscopic image and you have injected the dye, and that dye, right, it is there into the left atrium, and none of the dye is coming on this side, nothing, all clean, right? All clean. This is our right atrium. This is the indication that we have kept the amplitude very properly and that hole has been occluded, right? So this is amplitude in body. Now with this foundation, you will find that ventricular septal defect is so simple, so easy. All the principles would remain exactly same, exactly same. In fact, you have learned the entire acyanotic condition. So you learned ASD. Now only thing which you have to remember is that VSD is on a large scale because now the chambers are powerful. So that would be there. Similarly, when there would be patent ductus arteriosus, well, chambers are okay, but again the blood is getting mixed, so everything would come back in the same style. The coarctation of aorta, that is awesome, right? Because there'll be some very interesting changes. So that's how we'll go. So let's start with now VSD, ventricular septal defect. See how it is. Now in ventricular septal defect, I'll take you down to the basics of that ventricle. Just let me create some space. Okay, so over here, when we talk about right ventricle, so from right ventricle, it has got one, the inlet, and second, it is the outlet. In right ventricle, inlet is what? Inlet is the tricuspid valve, correct? Because it is coming from right atrium, right? So in between tricuspid, and it is going out in the form of pulmonary trunk. Okay, so far, so good. What about left ventricle? Well, in left ventricle, that is also there is an input and it is coming via mitral valve, and then there is, say, left ventricle, and from left ventricle, what is going out? It is aorta. All right. We feel that everything is fine, but do remember that portion when in the last stage of that embryo, that fetal heart development, there was spiral septum formation. Got it? right? Because we are over here, this is the right ventricle, this is the left ventricle, but aorta is coming out from the right side, and the pulmonary trunk is coming from the left side. This is pulmonary trunk. So initially, so there is no change, no differentiation, but it is then the aortopulmonary septum develops and it divides, and because it rotates, so that's the reason that there would be formation of something like this, right? And then it goes behind, and that's how the aorta opens. So that's why both of them, they shift, right? They rotate. If this rotation is not occurring properly, then also there is a problem, right? And then a big problem, very big problem. But sticking to this part, so when we know this thing, it means that what if this aorta or this pulmonary trunk, right, they are also into the chamber, and somehow they are involved into this ventricular septal defect because they are so close, so close. With that light, you just see that here, this portion, this portion, this is what is called as the outlet, right? From here, see, this is aorta, this is our pulmonary trunk, right? So that is outlet. This is what? That is superior vena cava, and that's inferior vena cava. So obviously this portion is our inlet. So that's inlet. This is outlet. And then rest of the structure, we saw thick, big trabecula, right? Big muscles. So those are that is the muscular part. That is the muscular part. So point is that actually this defect can occur anywhere. And wherever it is occurring, accordingly, we are giving some name to that, right? It is that simple. Wherever it is occurring, we are giving name to that. Now see, over here, when it is near, when it is near this, we call this thing as perimembranous, right? So there is perimembranous, or when it is, or the subarterial, right? When it is near to all those pulmonary and aortic valve. So here is the pulmonary, here is the aorta. When it is over here into this area, right? So it is the outlet part, but it is also called as the subarterial ventricular septal defect. When it is into this inlet, right, where it is near to inlet, that is the opening of this SVC IVC, we call it perimembranous or the inlet VST, perimembranous VST. And then for rest of the area where there is all trabeculi, and in then there if there is any defect, it is called as the muscular VST. So quite logical, right? Inlet, outlet, and the muscular part. Okay. See how it looks like. See, that's the interventricular septum. That's right ventricle, left atria. This is truncus venosus, and here it is the defect, right? Here it is the defect. Can you see all those musculature, right? Very nicely seen. So that is the VST. Technically speaking, it looks like this, right? That one is atrial septum. This one is ventricular septum, and that's where we see the defect, right? Left ventricle and right ventricle. So that is muscular VST. Here it is, where we see this is 2D echo, and in this we can very well see a clear defect, right? This is the septum, normal septum, and that's where the VST is seen, ventricular septal defect is seen. Now see, this is very rare. Sometimes you get multiple VSTs. Now what's the importance if there are multiple VST? Right? That's okay. Blood would flow from say so many areas instead of just one opening. No, the difference is that this thing, if it is like this, right, this thing can easily be handled with that occluder, right? Ampullate's occluder, you can easily occlude it. How will you do it in this case, right? It is not easy. And if we really feel that it is rare, here is the real image. When you cut, right, when you cut the heart, it looks like all those punched out holes, cheesecake appearance, right? That's how it appears. And when you do that 2D echo, see how nicely you can really actually see the defects. These are the defects. These are the defects. These are the defects. This is multiple VSD. I'll just remove this. Now you can see it properly. See. Okay. Let's see now how the X-ray would look like. We follow the same principle what we learned. Here though, just by look at it, we can know that there is massive cardiomegaly, massive, right? So this cardiomegaly is huge. But we'll see something more in this. What's that? In this, say, can you see the blood vessels till the end? Yes, you can see. See, right? These are all delicate structures, all till the end, till the end, till the end. Though this part is not very properly, but still you can see in upper part though they can see. See over here, here also they can see, seen very clearly. Now I remove this so that you can appreciate. Right? Till the end. And this part though is seen actually very nicely. See. Yeah. Right? See, it is seen so nicely. Okay. When it is like this, one thing is clear, that we are not dealing with Eisenmenger complex. It is not there. Right? Because in Eisenmenger complex, it is that all those vessels, right, till the distal vessels, they start decreasing. That is not the case over here. Right? Surely increased pulmonary markings. Increased pulmonary markings, they can be seen it over here. Cardiomegaly is seen. One more point which I would like to draw your attention. How about main pulmonary artery? In case of ASD, you found it very prominent, right? It was over there. It was looking like this. Correct? That was the thing. How is it over here? It's almost straight. Almost straight, right? This is straightening of left heart border, right? Straightening of left heart border. Now in such cases, when there is straightening of left heart border, see, anatomically we know that this left atrium is as such to is behind, correct? Right? It is behind. So you actually watch it like that this is left ventricle. But when this left atrial enlargement occurs, so it fills up this space and it gets enlarged like this. So it is enlarged. But as we said that all these radiological procedure in which the X-ray is involved, whether it is CT scan or it is this plain radiography, there has to be difference in the contrast. That is what is called as the differential contrast, right? Differential contrast. So in this case, so there is no differential contrast. As such, so they are same musculature filled with blood, everything same. So it will look like one. So with the left atrial enlargement, this area is filled up. This area though is already taken up by the left ventricle. So resultant effect is that you get a continuous border. This continuous border is the indication that we are dealing with left atrial enlargement. Because the shift of the shunt has not occurred, so that's why we can see that pulmonary markings till the end, and that's the case of the ventricular septal defect, because even the left ventricles, they are dilated. That's why such huge cardiomegaly. Okay, one more. Almost the same thing, right? This is cardiomegaly, and over here we can see all those pulmonary markings till the end. So that's our second point. And over here, right, it is the pulmonary trunk also enlarged, and left atrium is also enlarged. So we have got this 3, and this left ventricle is enlarged, that is 4. With this, compare with this, right? I'll just take off this. Compare like this area, right? See, try to see, say over here is seen nicely, right? See this part. Almost till the end, you can see the blood vessels. Now, do you see similar thing in the next X-ray? Watch it. Yeah, watch it. Do you find any change in this? Right? See, those, that is okay. This is main pulmonary artery is prominent. All right. But these vessels, right, they are not seen distally. They are not seen distally. See, suddenly you'll find that that area is cleaned up. So here, though there is increased pulmonary vascular markings, but they are decreased distally. Yes, we are talking about Eisenmenger complex. We are talking about Eisenmenger complex, in which there is reversal of shunt, and then now the shunt is from right side to left side, and that's the reason there is decreased pulmonary load, and that's the reason that we are not getting this distal vessels, right? Yes, no need to explain, I think, right? You have understood it by yourself. We are talking about Amplatzer septal occluder, but this septal occluder is for ventricle. So this is Amplatzer ventral septal occluder, and the difference which we would like to see is, see the size. The middle portion is large because ventricular septum is large, and they both are same size, right? Left side and the right side, they both are of the same size because both are high pressure chambers. Regarding the hemodynamics, now it is pretty easy. Initially, VSD allows left to right vein, right ventricle shunt, causing pulmonary artery, left atrium, and left ventricle dilatation. Then the pulmonary hypertension and pulmonary vascular obstruction, right? That's the Eisenmenger reaction, and right to left shunt, systemic desaturation leads to cyanosis, and then all the complications of Eisenmenger reaction, they eventually start. Small VSD, it many times it's missed. It might not cause any symptoms, but larger one, surely they will cause symptoms of congestive heart failure, right? Poor or small frequent feeding, right? Failure to thrive, babies not developing, tachypnea, right? Frequent respiratory infection, fatigue, and dyspnea on exertion, getting breathless. All these symptoms, they are common. And as Eisenmenger reaction eventually occurs, patient develops symptoms and complications of Eisenmenger reaction, right? That is syncope, and it may lead to death. Moving on to our next portion, that is patent ductus arteriosus, right? So in patent ductus arteriosus, when that was our like right main pulmonary artery, and then there was aorta, and in between it is ductus arteriosus. So here it is. That's the ductus arteriosus, right? Because main pulmonary is like this, and this one is aorta. So in between connectivity is, see, right? So that is ductus arteriosus. Here is the aortogram, right? This is the aortogram or the aortography. And in this you can see that this is the descending aorta, right? That's the descending aorta. And that's your main pulmonary artery. Pulmonary artery. And when you are injecting the dye, that dye is, see, it is getting mixed, and that's the presentation, that's the location of ductus arteriosus. And because it is patent, because it is open, that's why it is called as patent ductus arteriosus. Same principle, right? How will you really treat it? So this is the like a detachable coil for small PDA, right? A small PDA, so this is like a detachable coil. That coil sits over there and it leads to that obstruction, so that flow is disconnected. Or the Empletzer duct occluder, but again its size and shape would be different as compared to the, and this would be a bit smaller. Regarding hemodynamics, not much of the difference. PDA allows left to right flow, correct? Left to right flow. Think it like this. Pulmonary trunk is over here. This is the aorta. Aorta is under high pressure, and this one is under low pressure. This is on the right side. That's on the left side. There is a channel which is open, which was traveling from right side to left side during fetal circulation. Now, under the influence of prostaglandins, it was remaining open. Now placenta is no more, so prostaglandins are no more. There is higher pressure in the aorta, so after some time it has to be converted into ligament. It is not converting, so aorta would say, fine, there is an opening, let the blood go, and that's what is called as the left to right flow, right? Left to right flow. So when such large amount of blood is flowing, yes, it would lead to changes in the entire system. Pulmonary hypertension, sure. Pulmonary vascular obstruction, Eisenmenger reaction, that is when the shunt is reversed. See, for every shunt, right, there is left to right shunt, but then there would be pulmonary hypertension. So over here, the pressure has increased now so much that it would say, now no, everything is a pressure game, and there starts the reverse. And in that reverse flow, that is right to left shunt, there is no trouble, but the only trouble is that now the CO2, that deoxygenated blood is now going into this pure system, and the entire body is getting the mixed blood. When it was like a fetus, not much of the problem, but now there is a problem because we require much more blood, right? And finally, the coarctation of aorta. Simple thing, coarctation means uh, which shunt will be there? I'm sorry, I'm not getting. Which shunt means we are talking about Eisenmenger? Say shunt. No, today because it is acyanotic. Today we are discussing acyanotic. So that's why our shunts today are from oxygen side to carbon dioxide side. That means left side to right side, right? So that's why in none of our patients there is any cyanosis, there is no bluish discoloration, everything is okay. But because they are getting less oxygen, that's why they are feeling tired, they are fatigued, they are not growing, they are breathless, there is exertion on exercise, all those things are happening, right? But because these lungs, they are developing pulmonary hypertension. So as this pressure is rising, here is the culprit. It starts reverse. And it is this reverse shunt that is right to left. That is what is called as the Eisenmenger complex. That is what may lead to death at the later stage. Okay. So that way we saw that ASD, yes, blood can go from atria, left atria to right atria. Well, blood can go via VSD, right? So left ventricle to right ventricle, that thing can go. Or this is one, this is two, or it can use the ductus arteriosus. Ductus arteriosus, which was the connection between pulmonary trunk and the aorta. And this connection should have been closed, but it is now open. Now there are no valves, right? There are no valves into this ductus arteriosus. It is just a channel. It is just a channel, just open, right? So it's okay. It'll say during fetal circulation, the blood was going from pulmonary trunk to aorta. Now it is going reverse. So that's why this is our left to right shunt. But point is, after going over here, after going into pulmonary trunk, where blood would go? From pulmonary trunk, that blood would be dumped into the lungs. So again, it would lead to rise in the pulmonary tension. That is what is called as the pulmonary hypertension. When pulmonary hypertension increases, right, it will keep on increasing so much that now it is resisting against this. So it is at that point, yeah, one interesting thing is that during that transition phase, right, when the patient has got left to right shunt, so there would be a stage when suddenly symptoms would disappear. Symptoms would actually disappear. It is like that shunting has stopped, right? Because it is not a switch that from here straight away it moves from this point to this point, right? It goes gradually. So when right to left shunt develops, in between a state of transition when symptoms actually start disappearing, there won't be so much of exertion. You might see some growth also, it's proper. But remember, it's a very bad sign. It means the shunt is getting reversed, right? So that is Eisenmenger complex. And finally, this is coarctation of aorta. In coarctation of aorta, it is narrowing. Coarctation means narrowing. Some very interesting things are going to happen in coarctation of aorta. And they are, you know that this is arch of aorta, right? There is ascending aorta, arch of aorta, and then there is a descending aorta. From here, there would be the brachiocephalic artery. Then there would be left common carotid artery, and then there would be left subclavian artery, right? Then this brachiocephalic will be giving a branch to right common carotid artery, and then it would continue as right subclavian and further. Okay, right now we are interested in only this much area. What really happens is this. There are two types. One is the infant type and second is the adult type in coarctation of aorta. Coarctation means narrowing. So it is very vital that where the narrowing occurs, right? Where the narrowing occurs. Now to add something more complicated to this, what we are doing is, what we are understanding is, just for our understanding, we know that this is the portion which is supplying upper limb and head and neck. Am I right? Right? The subclavian will go further and finally it will be supplying the upper limb. This carotids, they will be supplying the head and neck. And this artery descending will go all the way down and then it will be dividing into that common iliac and then external, internal, supplying pelvis and supplying lower limb. So here is the lower limb, right? That was the upper limb. So over here, where exactly we narrow it down. So this is what is called as the coarctation. That means it narrows down, right? It narrows down. So here it is. In infant type, this is this narrowing. Say it is infant, right? Infant. So narrowing is after aortic arch and before ductus arteriosus. After aortic arch, so this aortic arch is complete, right? And before ductus arteriosus. So let's say here is the pulmonary trunk and let's make it over here. Sorry, we have to change this, right? Let me draw it like this. Okay, so pulmonary, and we draw the ductus arteriosus like this. Yes, right, ductus arteriosus like this, and our narrowing is before, say after aortic arch, right? After aortic arch, and over here before ductus arteriosus. Okay. Now will it make any difference? It would make a difference, because whenever anything is like, there is a tube, there is a pipe. If you narrow it down at one point, so there would be rise in the pressure, there would be increased pressure over here, right? And there would be decreased pressure over here because less fluid is coming. Over here there is fluid is accumulating, so there will be more fluid behind, less pressure further. Pulmonary trunk, right? This means this is the right side. This is the right side of the heart. Aorta, it is the left side of the heart. So over here, it is left to right shunt, right? So the blood would start going from left to right. But say we are talking about infant type. So in infant type, there is lower extremity cyanosis, right? And which is present at birth. Because of those obstruction, because of that narrowing, the amount of blood which is going over here to the lower limb, right, that is less, and they often do not survive because it is associated with even many other complications like Turner syndrome, etc. This is the female with not XX but just XO, 0. Now in adult type, there is no ductus arteriosus. So there is no mixing of blood, because over here so there would be mixing of blood, correct? There would be mixing of blood because this is truncus, this ductus arteriosus is there. So from here and from here, and this is, otherwise so it would have gone into the opposite direction, but because now the pressure has decreased, so even the blood from right side also it enters into the aorta. Otherwise aorta is a high pressure system, right? It won't allow, even if it is there. But let's say if there is no coarctation, right? So then the pressure over here, it would not be that high, right? It would not be that low. The pressure would be high, so it won't allow this. But over here, so it is happening that yes, this is low pressure, so some blood will seep out into this, and that's what is called as the lower limb cyanosis, right? It is the lower limb cyanosis. And in adult type, there is no ductus arteriosus. So what happens? Simply that aorta and it is constricted, and that aorta which is constricted and it goes. Simple, right? And they are like all those branches and but well, something more interesting happens here. That's okay, no mixing of blood, because see, pulmonary trunk is pulmonary trunk, that is separate, right? And this is separate. But remember, this is high pressure system and this one is a low pressure system. The entire game now starts because of those anastomosis, because body is not only made up of these aorta and pulmonary trunk, there are associated vessels. So now they will come into picture. See, there is a upstream situation and there is a downstream situation. So let's say this is what is called as the upstream, right? In upstream, there is high pressure. When this high pressure is there, first there is increased pressure in upper limb and head, right? And in head, there is circle of Willis in the base of the brain. There is circle of Willis, which is supplying blood to the brain. Now those are very delicate vessels and their walls are weak, so there would be, this is a vessel, so there would be the aneurysms. These are called as Berry aneurysm. These are all very small aneurysm, but they can be multiple, right? This is because of the weakness of the wall. Now wall is as such not weak, but it is the pressure which is so high. So because of high pressure, they lead to this Berry aneurysm, right? So this is one very dangerous. There can be aortic dissection. Pressure is high, so it is literally the aorta will give way, right? So there is defect in the wall of the aorta, right? And the aortic wall is affected because high pressure system, right? So wall is trying not to take the blood back, but then finally it would be affected. As compared to that, here is the coarctation, here is the narrowing, and this is the lower portion. Now this lower portion, it is what we'll call it as the downstream. Now in downstream, yes, in downstream, the situation is like there is decreased pressure, right? So in case of lower limb, when you see, you will find cold feet, weak pulse, right? And as they will walk, they will start getting pain, claudication, right? There will be pain in the legs. Also, it is not so. Descending aorta is supplying abdomen, it is supplying pelvis, and it is supplying the lower limbs. Now in abdomen, right, these are the kidneys, right? These are the kidneys. In kidney, there is renin, angiotensin, aldosterone system. This is one of the very fantastic system to control the blood pressure. So when there is less kidney perfusion, kidneys would think that, okay, we have got the problem, right? There is not enough of the fluid. So all the vessels try to constrict because we need to store the fluid. Result, there would be hypertension. The blood pressure, the pressure is decreased because of this narrowing, but kidneys, they won't understand it. Kidneys, so they'll say that whatever the blood which I am getting, I'll work accordingly. So it's telling you are giving me less blood, that means that there is decreased volume in the entire body, so we need to preserve. So all arteries, okay, shrink, become small, and we have got less fluid. There would be hypertension, right? Something more happens. Well, regarding treatment, balloon dilatation, well, you dilate it, right? But again, it is a temporary thing. This is the thing, surgical correction. That means you have to just cut this thing, repair it, and then it will, once this is done, it will change even the blood pressure symptoms also. Well, this reminds me that there was like one cardiothoracic surgeon, right? One cardiothoracic surgeon, right? He went to a mechanic, right? And he said that my car is not okay, just have a look at it. So that car mechanic, he thought that let me tease this gentleman. So he said, sir, as such, if you see, you are repairing human body, right? You are repairing heart, and we are repairing the engines. Engine is also like a heart, right? what it does, it also pumps this oil from here and there, and you are doing that thing on the heart. But the point is that when you operate on heart, you charge 2 lakhs, and when we work on engine, we charge 2000. What was the reply of that cardiothoracic surgeon? He said, no problem. Just for the comparison, all you need to do is you start the engine of the car and now open the pump, right? See how much oil comes out. That's the difference, right? That's why I said that we charge this much. Okay. So now we see something. Yeah, before showing you this X-ray, let me show you something. It is, say this is arch of aorta, this is descending aorta, right? And in this, in the thorax, right? In the thorax, you have intercostal arteries, right? These are intercostal arteries. In case of this posterior part, right, on the posterior side, these intercostal arteries, they come directly from the descending aorta. This is descending aorta. And in case of, say, this anterior intercostal arteries, they come from internal thoracic artery, which comes from subclavian, right? So basically everything is connected. So from subclavian you have got internal thoracic artery, and from there anterior intercostal arteries, they are coming. And what really happens? Well, no wonder they all anastomose, right? They all anastomose. So far so good. This is normal. But the day there is coarctation, now this coarctation will lead to what, as we talked about, that there would be decrease in the pressure. There was decrease in the pressure in the downstream, and there would be increase in the pressure on the upstream. True? When this pressure increases, this pressure would be transmitted here to here to here to here, and then it would start transmitting to this. So it means these channels, they would open up, and now the blood would start trickling along these lines. Right? Now these are the intercostal arteries. It means in between, what is there? In between there are ribs. There are ribs, right? There are ribs. Now these ribs, so here is a rib, and now there is a tortuous intercostal artery. This is tortuous because now the pressure has increased so much so that it is trying to go into from anterior to posterior. Now this is the tortuous intercostal artery. This tortuous intercostal artery, as it is pulsating, right? Because direct connectivity with the heart. So when it will keep on pulsating. Now let's say this is the rib. So with every pulse, it will keep on knocking it, right? That would lead to erosion. Right? When this erosion occurs, this is classically seen in third and fourth rib, commonest, right? Not seen in first and second because their intercostal arteries, they are way beyond. So this third and fourth, right, they will lead to this erosion, and that erosion will show what? They will show a very classical thing over here. This, that is called as the inferior rib notching. That's what is called as the inferior rib notching, right? Let's see the X-ray. See. Can you see this? All right. See this? Here it is, right? Here it is. This is inferior rib notching. Right? I'll erase it so that you can watch it again. See, right? That's what is called as inferior rib notching. Like this, it is going. I'm marking it, right? It goes like this and it goes like this. See over here, it is going like this and going like this. This is inferior rib notching, right? See here. So that is because of tortuous intercostal arteries. As those shunts have developed, and now due to those shunts, right, it is high pressure system is leading into the pulsatile intercostal arteries. So this was our fourth condition of the day, right? So tomorrow we'll be talking about cyanotic situations and plus AV malformation, atriovenous malformations. So that would be our congenital heart disease part 2. All right. Thank you so much and we meet tomorrow. Thank you and bye bye.